Well, thanks so much for joining our call today. This is Maura Enkelis, and I just wanted to welcome you to DII call on behalf of Brian Whitman, who can't join us today. Normally we start a few minutes after the hour, but everybody's been so timely. We have so many folks already that I think we should just start right on time. So I want to thank you. Thank you, Alison Hamilton, for joining us today. And I just wanted to briefly say also, I wanted to extend a great thanks for all of you who participated in help organize the DII symposium that we convened earlier in May. Thanks for participating, for all your feedback and participation, and for your evaluation results, which we have into consideration in planning future calls in addition to other activities. It turns out actually that we had already reached out to Alison to see if she could kick off the next wave of these calls. It turned out that she identified on the evaluations as a key person to engage, so we were happy to be ahead of the ball on that one. Just wanted to briefly say, and Alison, you'll introduce your research. You just wanted to say regarding patient engagement that we're really excited to have this topic presented today, and just to as a up that our next call in August will actually be on this theme as well. We have a patient who's involved in a number of advisory activities and also in innovation and prototyping as part of a national network who will be joining, and others as well, and Brian Whitman will be helping to facilitate that call. So without further ado, I just wanted to hand it over to you, Alison, and we're really excited to hear from you today and look forward to the discussion as well.
Great. Thank you so much, Maura. Can you hear me okay?
Yes.
Oh, great. So good afternoon. Okay, thank you, Ibrahima. So good afternoon, everyone. Thank you so much for joining the webinar today, which will focus on the importance of stakeholder engagement and implementation research. And I'm going to be using a couple examples from VA Women's Health Research, which I will explain to you in a minute. Just have a few to thank. If we could go to the next slide. So definitely want to thank VA for funding the efforts that you're going to hear about today, and several colleagues and teams and work groups and participants and partners. Take to name them all, but they are there, and I thank them from the bottom of my heart. Next slide, please. I'd like to do two things. First, to convey the importance of stakeholder engagement implementation research from the perspectives of researchers. So we did a study that I'll describe to you where we have researcher perspectives on stakeholder engagement. And then I'm going to talk a little bit about the Empower QUERI, which is an implementation program that I lead based here at VA Greater Los Angeles. I'm going to talk about the approaches that we're using to enhancing stakeholder engagement in our efforts. So we basically have two sources of information, two sets of perspectives on our topic of today's webinar. Next slide, please. So why do we think stakeholder engagement and implementation research is important? And I'll get into the researcher perspectives in a moment. But fundamentally, probably everyone who's on this call knows that implementation is supporting change in clinical practice, and change is very difficult. And without the engagement of stakeholders, next to impossible is not impossible. So you really need a lot of people on board at a lot of different levels to be able to affect change. We can't do it ourselves. As much as we might like to believe that we could as researchers, we know that we really can't take on organizational change, institutional change, clinical change without the engagement of different types of stakeholders throughout the entire endeavor. I think we've seen growing evidence over the years that engagement has the potential to improve the quality of many things. The intervention itself, fit between the intervention and the practice context, and of course, ultimately implementation outcomes. So it becomes really important in all facets and phases of implementation to have engagement of stakeholders, because what we do easy makes what we do better, and I believe personally that makes what we do more impactful and potentially more sustainable. Next, please. So we're going to model a couple of times today. This was adapted, and my colleague True, we adapted it more for a cyber seminar that you see referenced at the bottom of this slide. But this depicts three models of engagement: an advisory model, an employee model, and a partner model. So in the advisory model, the community members or stakeholders play an advisory role on the steering committee or an advisory committee. In an employment model, as the name suggests, the community members might be hired paid members of a research team. And in the partner model, the community members are partners or leaders in all aspects of the research. And you'll see in different studies and different implementation studies that one or more of these models might be employed. Next slide. The context for the first study that I'm going to tell you about under the umbrella of the VA Women's Health Research Network, which has three components. There's a Women's Health Research Consortium, a practice-based research network, which is a network of 60 sites designed to support women's health research throughout the VA, initially because there are, in some cases, not enough women veterans at any given VA to be able to achieve the sample sizes that we might want to see in research. The intent and the realization of the pre-PRN has gone well beyond that aspect of it in terms of increasing the recruitment of women into studies. Is an overall effort to increase women's health research in VA and focus on women's health issues in the different types of research that we do. So Becky leads the consortium, Susan Frame leads the PBRN, and I've been leading a study of multi-level engagement, which involves interview researchers, patients, providers, and administrators about stakeholder engagement in research. So our consortium, in our Women's Health Research Network, we embrace both the advisory and the partner models of the slide that you saw previously. Next slide. So studies I'm going to describe to you and share some data from to come up with the researcher sample. We literature and compiled lists of current and former the implementation scientists and interventionists. We reviewed these lists with our partners, and some of the participants recommended others. Since we're all folks who have done a lot of implementation research, some of the kind of founding people in the field, people who have done multi-site trials, and covering a pretty big spread of clinical issues and health services issues. Recruited by email, I invited 30 to participate, and 20 ended up participating. And asked them about their stakeholder engagement efforts across the research trajectory. So how did they engage stakeholders in planning phases, execution, and in discussion? Next slide, please. So for today, are some of the results related to just how these researchers defined engagement, what some of the common engagement approaches were, what consider stakeholders to be, which is a really important question and topic in this area, what they had to say about multi-level engagement and sharing results with stakeholders, and what engagement means for the researcher. What does it entail for researchers to engage engagement? And what difference does it make? Why do we do it? What's the impact? So in terms of just what is engagement, and as probably many of you know, I'm an anthropologist, and I like quotes. So you're going to be seeing a lot of quotes, not detailed summary points, and sharing a lot of quotes with you today. I hope that is a format that you all like. They say it in ways that I never say it as well, so figure I might as well share it in their own words. Researchers said that real engagement is about engaging people and creating an intervention, creating an educational component, creating whatever it is you're trying to do, and the community members, for example, veterans, actively engaged in this. Next slide. Types of engagement that they talked about in their research included early or formative feedback, interventions, measures, tools, methods. So in other words, stakeholders were giving a lot of feedback. Usually this was acquired via qualitative methods. Maybe stakeholders were reviewing different instruments that the group had to use in their research. different intervention tools, methods, recruitment approaches, interventions themselves. They also described having stakeholders involved in the advisory committees, and these had varying composition. Also having stakeholders as advisors or partners in their implementation research, and several of the researchers described having veterans on their research teams, and this was typically described by people who were doing consumer-based research, like having peer providers, consumer providers in their mental health teams. So that was a really interesting perspective on engagement, patient-level engagement implementation. Next slide. Stakeholders. A researcher said, oftentimes we think about stakeholders as patients, clinicians, so they're included in the mix and largely in the same way as with the patients. And some still do individual interviews or focus groups to get input on everything from recruitment to retention, and then to interpretation of results. So it's a pair process to that with patients. Next slide. Talked about engaging with providers and the importance of engaging with peers. And the person said they're the ones who are trying to help out, to do things different, or to set up different approaches that are useful to them. The intervention has to be carried out by the management of the sites, managers of the sites, and clinicians. They want to do something, excuse me, or they don't. So it's a matter of working with them to how to make things happen. So in there, engage with those folks very early in the process, people at the network and medical center level, that's VA terminology, are integral. They're really a part of the team. If you don't also engage with the providers in the system, by definition, it's no longer implementation research. And you'll see that highlighted some portion of these quotations that I thought might we want to discuss later. I think this is a really interesting statement about, if you're not doing something really specific with providers, then you're doing implementation, which I happen to agree with. I think it's a really interesting statement. Slide. Several of the participants also talked about the importance of organizational context. Researchers said we began to design our research around implementation with recognition that these VA networks or VISNs are the stewards of central office resources and that they have influence on what VA medical centers did. So working with multiple has been important. Finding out who to work with at each one of those levels took a lot of time, but if you want to do implementation, this is the infrastructure of the VA, so you can do all the provider engagement you want. They aren't supported by the head of medicine, and they're not supported by the chief of staff. No matter what you do with them, it's not going to sustain. National folks are a whole other level who set policy and practice initiatives and who wear different shoes. So this is really getting at what my colleagues and I have been working on in terms of multi-level stakeholder engagement, really thinking at who are the people, thinking about who are people at every level of an institution or organization, and how their roles have something to do with what you are aiming to achieve in implementation. So for those who know VA, it's a very multi-level, multi-layered organization, and there's multiple level of influences, and so really attending to all of those becomes critical in implementation. Next slide. We said that we are like multilingual people who can see all the different levels together and help them actually come to consensus, come to an understanding of what it might take to change things at the different levels. And it's fascinating that we are in this position because we engage veterans, we engage providers, we engage at each level, and that is why we actually provide some real value. Next. Quote focuses on patients. So the researchers said when the patients speak, either through their collective opinions in focus groups or interviews, or when at the table, clinicians and researchers pay attention to people we're trying to help. So that carries a lot of weight. I certainly don't see it as the norm, but I think as it relates to organizational or system change, it's hugely helpful if you do it at your own peril. So that's really on getting the patient perspective and making sure that the patients are at the table and that their perspectives are being gathered. Next slide. long quote, so I won't read the whole thing, but it's really talking about how, time is such an issue when it comes to implementation. People don't have enough time, patients, providers, they don't have enough time. But the researcher here, the participant here, said you just have to pay attention to how much of a burden you're placing on the providers. If they have some negative experiences that actually really get in the way, it can serve as a barrier to implementation. It can affect their willingness to participate in implementation studies in the future. So knowing what they have been through, what their expectations are, can be really critical. Of course, slides will be available if you want to read the quotes in more detail later. Along those same lines, this participant said you really can't do implementation without providers. It's kind of non-starter implementation 101. You can work with providers in a meaningful way. It's a collaboration, it's a partnership, and later in the quote, the person says it's mostly a foundation of respect and an accommodation with a little bit of facilitation and gentle pushing back and forth too. And I think that's a pretty great description of engagement, actually. Next slide. A couple slides deal with engaging patients. This participant, our experience with engaging veterans has really impressed upon me the importance of training researchers on how to actually be present, be honest, be clear about the expectations of what engagement means, but also the incredible promise for what engaging women veterans, that whole CVPR approach could mean. So I'm really excited and committed to that approach, but I think I can also do it more readily because at my career stage, I can take those risks because I think some of them are kind of risky and they're at the same time incredibly exciting and salient and help inspire and motivate what we do. And I thought this was really interesting because some of you may have heard, if you're in a more academic environment, that CVR type of work, community-based participatory research, highly community engaged, because it's very time-consuming, it might result in products other than or in addition to typical academic products. Sometimes it might not be rated as highly by the academic institution the productivity and impacts. And so some of these researchers who were more senior especially said you kind of have the luxury now to do more of this because they aren't under the same burden of the academic metrics and tenure metrics that some more junior folks were feeling like, I don't know if I can do as much CVR or heavily community engaged research because it might not be recognized academically. I think that's changing, but that might be another topic that we would want to talk about later. Slide. So one thing is of the interviews was about the dissemination end of things, and it's interesting because several of the participants expressed feeling some guilt around this, that they hadn't actually gone back to stakeholders and shared results as much as they wanted to and as much as they thought that they should have. There was sort of this moral overtone to this part of the interview. Here are a couple of quotes about closing the loop or sharing results. So usually by the time the study is done, the resources are gone and I'm working on something else. So I haven't had a chance to think about that. And then that's always a really important part of doing this, and it's something I have to be constantly keeping in mind. In the daily trials and tribulations of trying to actually make things happen here, it's a matter of staying in touch with the stakeholders. And the people who were very deliberate about making sure that a feedback loop was there talked how much planning it took. For example, in this, so where the person said our community partners really keep us honest about bringing back results. Now, from the very beginning, we're already planning how we're going to go back and disseminate so that it doesn't just fall off the end. Because a lot of times you get to the end and it's like, well, we've got to find funding for the next piece or something else. We did in even one of our aims on the community side to make sure we're disseminating in the community venues as well. So I thought this might be another interesting topic for us in terms of potentially building of intentionally ensuring that we have mechanisms built into proposals and projects to create that loop and ensure that it happens. Next slide. And entails for researchers. This was another very interesting part of the interviews where one person kind of encapsulated by saying you'd be somewhat egoless to do it. Another researcher said the biggest challenge is that it's really different from other kinds of research that we're more used to. Investigators who are unaware and not willing to see how much wisdom there is in and how much wisdom there is in the community are not going to get this. As you take that power dynamic of being like the researcher who's the expert and knows it all to come out to be a partner, and we're at this table and we all have strengths that we're sharing and we all have some things that we don't know. So sometimes it's cool for investigators to put themselves in the position where they're saying, there are some things about this I don't know. I don't know everything, so that's why I need you. So we talked about sort of a philosophical shift in how we think about ourselves as researchers and what we bring, but perhaps of even greater importance, what the stakeholders bring to us as well in our implementation research. Next slide. This person talked about it needs to be a win-win situation. So you go out and recruit people, you can have an advisory board. Really the emphasis is on directionality, especially once you get onto the CBPR end of the spectrum. Next slide. There's definitely a consensus around in my experience too, around long-term nature of engagement. It's an investment over time, as one person said. In the second quote, you'll see someone said that there's really a great way to gauge how much time it's going to take, but initial relationship building could take a year, it could take more, and that in the timeline is really important because there's so much that goes on in the early stages of engagement that are about establishing trust. That time, you can't rush it, you can't make it happen any quicker than it's going to happen. And, you know, sometimes, at least in traditional grant mechanisms, we don't really spend the time for relationship process because there's so much of the study that needs to ground running. There are some really nice mechanisms in QUERI and elsewhere that provide funding for that time to build relationships. And I hope that we're going to see more and more creative ways to take the time for that early stakeholder engagement that really sets the foundation for the implementation research. Next slide. Engagement make a difference. One participant said that the Strategic Veteran Council has given us a really strong sense of what their priorities are. That helps us understand how to both frame and prioritize the many analyses and papers that we may do. Another, because we hire peers and because they're so intimate at the work with that we do, I'd like to think that builds a lot of trust. They're eyes and ears, so we wholeheartedly want to get feedback from them, and really we change course based on their half of the equation. Another said, when you take your end user and have their input at the beginning of the creation of a project, it's gold. So I really, quite frankly, have a understanding why people don't employ this systematically. Next slide. So just to talk very briefly about the Empower QUERI. In terms of, where is engagement going, I'd say the consensus in this group was certainly that it's not going to go away. It's not a passing fad, and that hopefully that it will evolve and hopefully become even more central to what we do and become more built into how we do implementation, how we set it up. And another said change is hard, but that doesn't mean we shouldn't change. Next slide. So now I'll talk briefly about the Empower QUERI, which stands for Enhancing the Mental and Physical Health of Women Through Engagement and Retention. The QUERIs, for those of you who don't know, are the Quality Enhancement Research Initiatives funded by VA. There are now 15 throughout the country of this particular type of program, which is a multi-year implementation program designed to address cutting health needs of veterans. Our particular Empower query that I lead with Dr. Bevan Mayberry and Dr. Tanaz Moen, our goal is to improve veterans' engagement and retention in evidence-based care for high-priority health conditions, which are diabetes, cardiovascular risk, and depression and anxiety. To design this program, we use community-engaged research principles, and we felt really important to have multi-level engagement as a core strategy, and I'll show you a visual for this in a minute. And we also wanted to prioritize patient engagement in care. So we prioritize patient preferences in all of the care models. They all offer patients a couple of different choices as to the types of care that they can engage in for their conditions, depending on their needs and circumstances and preferences. And then we're examining, make a difference, what types of choices do women make, and how to impact their care experiences. So if you recall the diagram I showed you earlier, we are using all three of these in the query, where we have stakeholders as members of our team, as well as advisors, as well as partners, multi-level stakeholder partners. Next slide. This is not meant to get us into the weeds, but more just to show many different initiatives led to and kind of contributed to the Empower query and all of the stakeholder engagement. It would take days to describe all of the stakeholder engagement in each one of these little flags that you see here, but part of what this is the really partnered nature of the work that we do. So one of our key stakeholders in the work that we do in women's health at VA is what we call operations partners. So those are the national in the field who are very fortunate to have a strong relationship with, who can let us know what their priorities are, and we can work together to figure out what types of research we can do that would be responsive to and informative for those priorities. So the strategy that we're using in the Empower query is the replicating effective programs. Implementation strategy, also referred to as a framework. REP, some of you might be familiar with REP. It was initially developed by the CDC. And what we decided to do, we like this framework a lot, first of all, because it's an evidence-based implementation strategy. So several that have used REP and have demonstrated that it is an effective approach for implementation. So it meant that we weren't using strategies that haven't been tested. It nicely packages up strategies across a phased approach, which I would recommend for any implementation study. You need phases in a way to break down what's happening when, what you're measuring when. And we decided to do with this framework was enhance it with stakeholder engagement. So it might be a little small to see, but in each of the boxes, there are italicized portions, and those are things that we added to the model that really highlight stakeholder engagement during each phase, and also commented it with complexity theory, just because the theory provided us with some directions to go in terms of addressing the high level of complexity that we were facing in women's health in VA. Slide. There are different levels and timing of engagement. So as I mentioned before, we have these national partners who are in this with us all along the way. We have 5 national partners who are involved in every phase, have leadership at the vision level, leadership at the facilities where we're doing implementation. We have our stakeholders at the women's health clinics who are involved all along the way, providers and staff, and of course patients. So we tried to and are continuing to try to ensure that stakeholder engagement is front and center in each phase, and with varying degrees at each level, depending on what's happening at any particular time in implementation. Slide. hope to see in the Empower query is at the patient level that their care is tailored to their needs and preferences. All of this is very much underway. In fact, implementation is launched today in one of our studies that we're so excited about. So I can't tell you whether these impacts have been achieved, but this is our goal, is for the patient to have care models that are tailored to their needs and preferences, and that results of that tailoring, they have improved health and satisfaction. Providers, we want these models we want to be able to support them for implementation of the care models, and in doing so that their satisfaction is increased. At the level, we want these to be care models that are feasible to implement and pretty tailored to local context. So even though we have some core components, the idea is that we know that we need to tailor them pretty extensively for them to fit into each very different clinical context. And finally, as I mentioned with our partners, our goal is really to make sure that we're providing them with useful information and with care models that can be spread so that the health conditions that we're addressing will actually be improved and managed. Next slide. Wrap up. I just came across this recently, but I thought it might be handy for this audience. And colleagues came up with a stakeholder engagement report questionnaire. And I just copied it right from this. I didn't adjust anything from the article where the checklist is found, but I think it could be a really useful tool just to think through all these different aspects of quality and content of reporting stakeholder engagement, about who was engaged, how many were trying to be engaged, what's the balance of different perspectives, what methods were used, when did engagement occur, what was the intensity, what was the impact. So I thought, it would be useful to use this to report on stakeholder engagement, but also even to think through setting up a project that has stakeholder engagement and kind of looking through this and making sure that you've specified all of this information. I just thought it was a really useful question to help guide efforts in stakeholder engagement. Next slide. We found, and what we heard in our interviews, and many others have found in stakeholder engaged research and quality improvement, is that engagement can help with a whole host of things. Identifying priority research topics, selecting and designing an intervention or a tool or a measure, adapting and tailoring strategies, adjusting what's happening in implementation, promoting buy-in. I'm guessing everyone on the call knows that buy-in is absolutely critical to implementation. Engagement can really support consumer demand and engagement in the work that we do. It can address barriers and challenges. It can help us think about sustainability and scale up and spread. Engagement can inform policy and practice. And I think really fundamentally just foster trust, transparency, and reciprocity so that the research we do is more impactful and more meaningful and changes what we're out trying to change. So I think my last slide is my contact information on the next one. So now I'm hoping that we can just discuss anything brought up or anything I haven't brought up that you want to ask about, talk about, but I'm open to questions, comments, feedback, criticism, whatever you may have.
Thank you so much, Alison. It was really a phenomenal presentation and introduction to thinking about these topics. I just sent a note to encourage anyone to chat in any questions that you have, and all unmuted now, so we'll give advice. So anyone who has a question, feel free to put it out there, and we'll just go in order. Anyone have any questions or comments for what Alison just presented?
Yeah, there's a question in the chat. How does Hamilton the research literacy among patients to ease participation?
How do I handle research? Did you say security?
Literacy.
Oh, literacy.
Among patients, yes.
I think it's a fantastic question. I think it's probably, for the most part, very project specific. I think there are a couple of different kind of pockets of literacy that we need to think about. There's literacy related to the content of the project itself, the project goals, and so forth. There's some feedback on the line. I'm not sure if it's distracting folks.
Yeah, muted the person. Sorry, but.
Oh, that's okay. The literacy pertaining to the topic of the research itself, but then there's literacy pertaining to processes of engagement, what it means to be a subject. I think there's been some materials developed along those lines, probably that I'm aware of have been developed by PCORI, and they have really gone to some great lengths to develop materials for patients who are engaging in research in a number of different ways. And there's even some not super old work, but older work about participation of vulnerable subgroups in research, and from the participants' perspective, work by Joseph Trimble and others that I think has laid out a really good foundation for increasing literacy. An excellent question, though, and probably something we don't feel has been done enough. It's something we need to keep doing and keep thinking about in each project and really tailoring our approaches in each project to ensure along the whole process of the research.
Thank you. Questions? If people are, so we were saying, Ibrahima?
No have any other questions.
Okay. Well, folks are thinking, and feel free to chat in your questions and maybe send to everyone, and then I'll be able to see it. While you're thinking about questions, I was wondering, Alison, if you had a thought about what changes or what helps to build a culture, particularly within an organization that has traditionally been sort of hierarchical, to help people become more comfortable with even asking the question, how did that go for you, or how could we make it better? That is doing just getting feedback from people as part of a process, and just wondering about some of the aspects that help with that kind of culture change. Very broad question, I know, but
yeah, so that's a big one. I mean, I think it starts with us as researchers, and being willing to hear what it is that people might say in response to the questions that we ask that might give us a little bit more critical feedback, things we might not totally want to hear. And so it kind of goes back to that one quote where Gibson said, you really have to be egoless to do this, because you have to be willing to hear that doing things in the right way. You're not doing things in the way that a particular community would prefer or that they find valuable, and that can be difficult to hear. So part of the challenge of what you bring up is just what I'm kind of ready to take in. And once you're asking for feedback, you have to commit to making changes based on the feedback. And so that's another, part of it is, well, we're not just getting people involved for the sake of getting people involved. We're actually trying to do things different by virtue of this engagement. And I think what enhances the trust and transparency is seeing the actual commitment to doing that. So, just saying, oh, yes, we'll take your feedback into consideration, or we'll think about changing something the way that you suggest. But if stakeholders don't see actually followed through, and not necessarily done it exactly the way they asked, but that you followed through, you considered the options and made changes that made sense for the team, the project, the setting, et cetera, and really temper things if they're not seeing the commitment to follow through. So I think a lot on us as researchers to kind of open up that dialogue and create those pathways, but it doesn't end with opening them up, I guess, is my take home point. That's the beginning of how this can inspire. it's not linear. I mean, since I've been doing much more community engaged research, you know, it's very humbling, and it's a lot of ups and downs, and you learn a lot about who you are as a person, you know, in terms of trying to meaningfully and genuinely involve stakeholders in the work that you do. It's quite an experience, one I would not do without, but it's not an easy path, I would say.
Great, thank you. Are there other questions? Otherwise, I can spin with another, but it's coming up.
There is a question on the chat that asks, how do you work to ensure that the relevant organizational stakeholders are included?
A lot of questions. I mean, it's a great question. And usually if we're entering into a new field or a new area, maybe a geographic region, we probably don't know much. And so, you know, that sort of an ethnographic approach, as you're starting to learn about who's the key informants, who kind of knows what's going on. Even in our studies, you know, one of the first things that we'll ask in our pre-implementation interviews is, okay, who we think we know who we should be talking to, but can you just let us know who is critical? And it might be people, it might be organizations, you know, depending on where you're doing the work. But usually from sort of that snowball perspective that you're going to start learning, you know, who is critical for you to be learning from. And that won't always be people who are organizations who are going to tell you exactly what you want to hear. And so being open to that is really important. But mostly it's doing a lot of homework, a lot of reading. If you're doing community-based implementation, attending community-based events, figure out who the key players are and how you can, you know, get access to them, oftentimes through word of mouth or different relationships and connections. But it's time. That's that initial period that that does take time, that one of the participants talked about in terms of just building relationships, finding out who's who, finding out who relevant stakeholders are. And, you know, it's not always going to be perfect. You're going to find out 6 months later, oh, we really should have been talking to this other group or these other people. And then you go and add them to the mix. And so I think it's letting go of everything being perfectly set up in the beginning and saying, I'm just going to learn as I go and talk to as many people as I can and get as much input and feedback as I can to find out who the players are.
So we do have another question. Ask regular models of engagement, is one model preferred or considered stronger than others?
It's a really good question. I think, you know, it depends on what you are looking for in your project and what level of engagement would be appropriate. I think there is definitely momentum around health services research, at least in some pockets, kind of saying that the advisory model is not so sufficient anymore. It's necessary. I think you need stakeholders in advisory roles, but it's really everything that it could be. And, you know, in the VA National Veteran Engagement Work Group, we've been working with leadership to figure out, okay, how can we put the envelope a little bit more in health services research, try to increase veteran engagement in our studies, because anyone who's done this type of work knows the value of it. So even though I've said it's hard and it's time, it's incredibly rewarding and it's incredibly impactful. And I think that, you know, within the VA context, there's a high level of recognition of that. So I wouldn't go so far as to say one model is better than another, but I personally am moving more into the PARD models and more partner and engaged my work is, I feel the better it is. So I can speak from a personal perspective, and I think that the data that I shared with you would be consistent with that perspective, which is, you know, we need more than just to check in with our advisors once a year. We need, you know, stakeholders who care, or, you know, who we would like to care about this research. We need them involved in much more than just that. But there are, you know, definitely going to be studies where that level of engagement wouldn't be necessary or appropriate or feasible. I don't want to say it would be bad to have that model, but just, you know, pushing more toward more engaged research, I think is where a good version of the field is heading.
Okay. So next question: is there a danger of getting multiple perspectives that can result in opposing perspective on an issue and make implementation more difficult and more political?
Great question. I think it's actually pretty guaranteed that you're going to get different perspectives that don't agree with one another, and that is, you know, sort of the beauty of it and definitely the challenge of it, because we would like for everyone to agree and say, oh, what you're doing is wonderful, and we think it's just fantastic, and please do more, and have us do more, and it's just not reality. So I think, you know, we can basically expect that we'll get some opposing perspectives. And I mean, I think it's a really interesting tension, because when certainly in a lot of the work that I do, I get very diverse opinions and perspectives that I couldn't possibly accommodate entirely. And so there comes a certain time, and I think this happens with the trust and transparency that you want to establish with your stakeholders, is to say, okay, I considered, you know, these 4 perspectives on what we should do next, or what the intervention should look like, or, you know, some other aspect of implementation. And, you know, here's the decision that I'm leaning toward, and get their feedback on that. I think in a lot of cases, you know, stakeholders, as anyone, any humans, want to be heard and want to be recognized, and want to know that their perspectives are valued, and know that, you know, there's no way you're going to be able to accommodate different opinions about something, but showing what conclusion you reached and considering all those different opinions, I think, is a really important part of just maintaining transparency, and knowing that not everyone is going to be happy with you all the time, and being okay with that. You know, not being able to satisfy all stakeholders all of the time. It's just not realistic to think that we can, you know, keep everyone happy with everything we do all of the time. But I think what's different about engaged research is that we're more upfront about that, and we're more willing to say, hey, I made a mistake, or I had to do something that this one stakeholder didn't agree with, and, you know, willing to accept the consequences, and knowing that some people might not be so happy about that. That can happen. But I think it's important for me to realize, when things like that do happen, is that it's not necessarily a deal breaker. You know, the end is not in sight. If you thought that, oh, I wasn't able to accommodate the perspective of a particular stakeholder, had that, and I thought, oh my gosh, everything's going to end. You know, the project's going to fall apart, or whatever it be, and then you realize, oh, we can move on. It's something we can talk about and figure out, and then we can move on. And the end did not come as I thought it might have. So it's important to make it through those bumps too, and just realize that that's what happens in relationships, because that's what is really happening with stakeholders, is you're building relationships with them, and they're not going to be perfect.
Okay, thank you. And we have one more question.
Sure.
What practical advice do you have to successfully engage high-level hospital leadership or administrators who frequently have multiple competing projects or issues to support with limited resources?
That's a fantastic question. I think more and more what we've been trying to do in our work is figure out how can we get to impart into a pretty tight soundbite. So if I can, talk to a facility director or a regional director for 10 minutes, I need to use that time very wisely, and so I need to be super clear about what I'm trying to get from that interaction and what is the minimum necessary information that I want to impart that I believe will actually matter to that stakeholder. Usually with higher level folks, it takes a while to get to them, and you might need to get to them through the existing hierarchy. So from person to the next who says to that high up leader, hey, it's okay for you to talk to Alison, given minutes. So that's the way sometimes these highly hierarchical organizations work. But then being prepared for it to be an extremely time-limited interaction, and so knowing what it is that you expect to get from it if you only have 5 or 10 minutes. So I think just the time associated with trying to interact with these folks, you may get more time than that, but you want to expect that you won't. And then if you more, you're happily surprised. Being very clear on how to make the most use of time with this higher level person.
Okay. All right, thanks. That was the last question on the chat.
Okay, great. They're all fantastic questions. Thank you, everyone, so much.
Great so much. I think I have an innovation poll to launch. Is that right?
Yeah, correct. Yeah.
So we'll give you just a moment to do that, and maybe with just one other last question to close things out.
Yeah, sure.
And that was, I wondered if you have thoughts about how institutions or IRBs, mentors, and others could make it easier for us to guide protocols as they're developed. So I know, as you were saying, there's the sort of the conventional, come with the idea and do some prototyping and pilot testing, and then move into implementation. And often folks write protocols after the pilot, and then partly engaging stakeholders, providers, and others, you learn things during implementation, and sometimes our protocols aren't written with the kind of flexibility to accommodate it. So I wondered if you had any thoughts or guidance on how we can help people not build that into their protocols, so they're not suddenly in the middle having to go back for approvals for small changes, things like that. Thoughts you have on that?
I mean, I think, Maura, you kind of nailed it on the head when you said build in the flexibility. So what we try to do in our implementation protocols is acknowledge in different sections, here are some scenarios of things that we think could happen, and here are the ways that we are going to accommodate those changes. But we also say something like, we can't possibly account for everything that may happen. Of course, if anything happens that has IRB implications, we would go back and do a modification if it really changed, the way we were collecting data, the way we were interacting with people. But try to acknowledge explicitly in the protocols where we expect there to be some predictability. Like, for example, you might learn in interviews, mid-implementation interviews, that your, whole aspect of what you thought would be happening isn't happening, and you need to change course and implementation in order to respond to the feedback you got. Now, that's probably going to mean change in your IRB protocol, but what we would have had in place already was the statements about the information that's gathered during that data collection episode would be informing what happens next, and we would have to, go and modify based on the feedback that we received. So, I think that IRBs are getting more in the types of institutions where we all work. They're getting perhaps more, I would like to believe, more and more used to implementation research and its kind of unique components and qualities that make it a little tricky. But I think as much as possible, just acknowledging where we expect some of that to happen or some of that feedback to potentially change our course, help the review committee know, okay, well, they are acknowledging that things change, and they know that they're going to have to tell us if they do.
Thank you so much. That's so thoughtful and so helpful. That's great for all of us.
Good.
So just want to thank you again so much. We'll let everyone go maybe a minute or two in advance of the hour so you can get to your next call or event. But Ibrahima did just post an evaluation, so we'd really appreciate if you can just, before you leave the call, just respond to the polling. It really helps us so much in planning our next calls. I want to thank you so much, Alison. That was really fantastic.
Well, thank you so much for having me and for all the great questions and for all the work that you're doing in SoCal, DNI.
Yeah, thanks everyone for joining the call today and for all your great questions. And our next call will be on August 2nd, I believe, from 12 to 1. So we'll send out an announcement soon about that. But I think it will also be exciting and follow up on some of the conversation we had today. So thanks everyone so much, and look forward to talking to you soon. And yeah, please complete the poll. We really appreciate it. All right.
Thanks, Laura, and thanks for
Thank you.
Thanks.
Bye-bye. Bye.